Hello friends, welcome to my channel. I am here to talk about local anesthetics. So local anesthetics are drugs that act on the nervous tissue and they cause impaired nerve transmission, nerve impulse transmission. So these are the drugs. They act on all the excitable membranes of the nervous tissue, like they act on the dendrites, they act on the axons, they act on the cell body, and they also act on the axon terminals. So they act on all the excitable surfaces of the neuron, and they cause impaired nerve transmission when they are applied in appropriate concentrations. When the drugs are applied, they lead to sensory and motor paralysis in the areas in which the nerve supplies. So if the particular nerve supplies the hand, then in that area alone there will be sensory and motor paralysis. And the action of the drugs are reversible. When the drug moves away from its binding site, the action of the drug is reversed. And the first drug to be found was cocaine. Even though cocaine was really addictive, it was still used for the first 30 years, and then procaine was found. After that, now we are using lignocaine. Lignocaine is being used until now majorly in all the hospital situations. Now let's move on to the chemistry of the local anesthetics. So what do you think local anesthetic? Is it a base or is it a acid? Yes, you are right, it's a base. Now let's continue with the chemistry of local anesthetics. The local anesthetics have a lipophilic aromatic group which is labeled as X, and hydrophilic amino group which is labeled as Z, and ester or amide linkage which is labeled as Y. So let's call the local anesthetic XYZ. One fact is that esters are more prone to hydrolysis than amides. So if there is ester linkage instead of amide linkage, then ester linkage is more prone to hydrolysis. What happens if they get hydrolyzed? If they get hydrolyzed, the bond between X, Y and Z will get degraded. So the anesthetic is degraded and it becomes separate X, Y and Z. So it will lose its function. What can we determine from the fact that esters are more prone to hydrolysis? We can say that esters are short acting, because as soon as it's introduced into the body, most of the esters gets hydrolyzed, and because of that the anesthetic will lose its function. So one more thing is the infected wounds. Infected wounds are acidic and the local anesthetic is basic. So if since infected wounds are acidic, the local anesthetics will ionize in the infected wounds. So most of them will ionize, and only a few of them will be left to reach the neurons, and only a few of them can show their action on the neurons. So in infected wounds, local anesthetics are less effective. So the three main points in chemistry is, the first thing is that local anesthetics are basic. The second is that esters are more prone to hydrolysis. Therefore, the local anesthetics having ester linkages are short acting than the local anesthetics having amide linkages. The third point is that in the infected wounds, the local anesthetics are less effective because they ionize easily. Now let's move on to the next topic, that is the classification of local anesthetics. Local anesthetics can be classified based on the route of administration and duration of action, and they can also be classified based on whether they have a ester linkage or a amide linkage. Now let me revise it again. Ester linkages are more prone to hydrolysis, so they are short acting than amide linkages. So let's start with the drugs having ester linkage. First drug is cocaine. Cocaine is also a surface anesthetic and it has a ester linkage. Then procaine and chlorprocaine. Procaine and chlorprocaine, since they have a ester linkage, it also means that they are short acting. So procaine and chlorprocaine are not only having ester linkage, but they are also a short acting injectables. Then comes the benzocaine. Benzocaine is also a ester linkage and it is used as a surface anesthetic. Benzocaine is used as a surface anesthetic. Then comes the tetracaine. Tetracaine is also having ester linkage and it is also a surface anesthetic, and surprisingly it is a long acting injectable. Then now let's go to the amides. The drugs having amides linkage are lignocaine, bupivacaine and mepivacaine. Lignocaine is both a surface anesthetic and an injectable, and lignocaine comes as an intermediate acting injectable because it is having amide linkage. It has a longer duration of action. Then it's the same with bupivacaine and mepivacaine. Bupivacaine and mepivacaine are also long acting injectables because they have a amide linkage. and tetracaine, which is also having ester linkage and surface anesthetic, is a long acting injectable, the only exception. Now let's move on to the next topic, that is the mechanism of action of the local anesthetics. So usually the sodium ions can freely pass through inside the nerve cells, which causes a generation of action potential. But now what happens is the anesthetics will block the sodium gated voltage channels, and the sodium cannot enter the nerve cells anymore. This increases the threshold for excitation, and the action potential is not generated anymore. Now let's talk about the differential blockade. What is the differential blockade? The differential blockade says about how some nerves are blocked faster than other nerves, and the best example is the smaller nerve fibers are blocked faster than the large fibers because they have a small length and they have a large surface area. So since they have small length and large surface area, it is easy to block the smaller fibers than the larger fibers. And some example for the smaller fibers is autonomic fibers, and some example for larger fibers is sensory nerve fibers. Therefore, autonomic fibers, which are small, get blocked more easily than sensory fibers, which are larger. Then also one more thing is that the myelinated fibers get blocked faster than the non-myelinated fibers. Now let's go to how the local anesthetics are used in the hospitals. In the hospitals, we often see that the local anesthetics are combined with either adrenaline or phenylephrine. So when local anesthetics are combined with adrenaline in the ratio of 1:100,000 or 1:200,000, or otherwise local anesthetics is combined with phenylephrine at a ratio of 1:20,000. And why do they do this? Because adrenaline and phenylephrine are sympathomimetics. So they cause vasoconstriction. Since they cause vasoconstriction of the blood vessel becomes shrunken, and this allows the local anesthetic to get absorbed more slowly into the blood vessel. Since the blood vessel is shrunken, the absorption is more slower, and since the absorption is lower, the local anesthetic can be long acting. And also one more thing is there will be low toxicity. Since absorption is slower, then only small amount of local anesthetic will be present in blood. So there won't be toxicity of the local anesthetic. So slower absorption, which causes prolonged action, and also less toxicity. So that's why they use a combination like adrenaline and local anesthetic, phenylephrine and local anesthetic. Thank you for listening to my video. I hope you like this video. Please like, subscribe and share. In the next video, I'll be posting more about the local anesthetics. So wait for local anesthetics part 2.